Welcome to our webinar today with the Upper Midwest Telehealth Resource Center. My name is Becky Sanders, and I will be leading you through Foundations of Telehealth, a focus on women's health today. This program that we're doing via webinar today is done in conjunction with Ohio State University and the Ohio Department of Health. We'll send out an email to everyone who is registered today, also giving you the links to the simulation trainings that they will be doing throughout the month of September on the 1st, I believe it's the 16th and the 28th. And this work is done as a part of a HRSA grant to train maternal health providers on incorporating telehealth into their care for patients. So with a focus on, a little bit of a focus on COVID, even though we had the funding prior to COVID. So I'm Becky Sanders. I'm a senior director at the Indiana Rural Health Association and have been the program director for the Upper Midwest Telehealth Resource Center since 2012. Everyone is in listen-only mode today. We will record the session. We are going to post the recording on our YouTube page and on our website, along with a copy of the slides. All right, let's go ahead and get started. So I can't talk about the work that we do here at the Upper Midwest Telehealth Resource Center without talking about the National Consortium of Telehealth Resource Centers. So we are all funded through HRSA, through the Federal Office of Rural Health Policy and the Office for Advancement of Telehealth. At the Upper Midwest Telehealth Resource Center, we cover the 4 states of Illinois, Indiana, Michigan, and Ohio. You can see by the map that there are also other regions around the country. Every single state in the United States is covered, including the Hawaii or the Pacific Islands. Pacific Basin Telehealth Resource Center covers Hawaii and American Samoa, the Federated States of Micronesia, Guam, and some of those other territories. We also do have 2 national telehealth resource centers, one for policy and one for technology, and I'll be mentioning those a little bit as we go through today. So we do have a national website for the National Consortium of Telehealth Resource Centers. We do host a monthly webinar that generally falls on the 3rd Thursday at 2 p.m. Eastern each month. You can get to that through the website. There's also an interactive map that you can reach out to any of the 14 telehealth resource centers across the country. And when people ask me what I do for a living, my 30-second answer is I'm a virtual librarian. And people are like, what? But that's a lot of what we do here. We answer questions that come in through email, through our website. Before COVID, we saw people in person at conferences, that type of thing. So we do a lot of what we call technical assistance, answering individual questions regarding reimbursement. We'll talk about consent, licensure, all of these other things. I mean, we do a lot of trainings, especially since March of this year. We've done a lot of trainings online and have been archiving them on our website. So these are our objectives for today. We're going to define virtual care and provide examples of asynchronous and synchronous care. We're going to describe workflow considerations for virtual patient visits and provider consultations. We're going to provide examples of best practices for virtual visit etiquette, so virtual visits, focusing on that today, and then outline ways to incorporate elements of physical examinations into virtual visits. So starting with defining virtual care and examples of asynchronous and synchronous care. First, I want to talk about the terms telehealth and telemedicine. And these terms have been around for a long time. The overarching term telehealth really covers is the entire umbrella for all of these things that we're going to talk about today. And it does include group counseling, group education, remote monitoring, chronic care management, all of those things. And then telemedicine really is that billable clinical event between a patient and provider when they're at a distance from each other. Newer terms that have come up in the last 3 to 5 years and are becoming more and more popular now that COVID has brought such a huge impact, or brought telehealth from a small niche service to a much larger scope of practice. We hear mHealth, we hear eHealth, video visits, virtual care, but all of these terms are used to talk about how do you take care of a patient when the patient and the provider are not in the same location? How do you use technology to deliver that same clinical care that you would if the patient was in the same room with the provider during a typical clinical visit? So the terms asynchronous and synchronous. Asynchronous is a one-way communication. So think about an x-ray. Or dermatology is a great example of asynchronous. Someone takes a picture of a skin rash or a lesion, it gets sent off to a dermatologist for them to read, and then it comes back to whoever took that picture, whatever, maybe it's the primary care physician. So data and pictures are really good for asynchronous. Synchronous is like a two-way walkie-talkie. It is live, it is interactive, and it contains both an audio and a visual component. We know that with all of the 1135 waivers, so HIPAA requirements are waived right now, and we're not going to get too deep into technology, but there are platforms for audio and visual communications that can be used right now during this public health emergency that wouldn't normally be able to be used because they're not HIPAA compliant. Here at the UMTRC, we do strongly recommend that you choose a HIPAA compliant platform because at some point that waiver is going to go away. And then telehealth is a delivery mechanism. It's not a service in and of itself. You are delivering the same clinical care that you would if you were in person with a patient. Talking about flavors of telehealth. So these are just different broad categories. Hospitalists and specialists is some of the easiest type of care to implement. So you have a rural hospital, someone comes into the emergency room, and then you have some kind of an arrangement with a teleneurologist or a telecardiologist to help deliver care to that patient so they can be treated appropriately and hopefully remain in their local community but receive the best care possible without having to transfer them to a urban medical center. Integrated care, here we're talking about using telehealth technologies to bring virtual care more into a primary care practice. So primary care medical homes and the accountable care organizations are very popular here. We've just started to see more information about the new chart methodology that has come out of the Trump administration, so we'll learn more about that. That might fit in here as well for rural healthcare delivery. And then transitions and monitoring, and here's where chronic care management, remote patient monitoring fits in. Also, this is kind of covers the community paramedicine, the thought that a paramedic could do house calls to patients and get paid for that without actually sending the patient or delivering the patient to an emergency room. And then the last one has gained a lot of popularity over recent years is primary care in schools. So equipment is brought into a school system where the school nurse or another employee of the school system is there to help triage the patients. If they decide they really do need to see a pediatrician, a nurse practitioner, a physician assistant, then they accomplish that via video technology and digital technology that is secure and HIPAA compliant to get that kid seen and hopefully get antibiotics on board if they've got strep or an ear infection or something like that. We've also seen huge successes with kiddos for behavioral health treatments asthma, those types of things. All right, so let's dive into our second objective, which is workflow considerations. So here we're talking about how do we redesign your clinical workflow to incorporate technology into it. So when you develop a telemedicine program, there's some basic tenets of that. You need to assess and define what program it is that you want to do, what service, what clinical service do you want to provide. You need to assess the market for that, and then develop and plan your work plan. And then you're going to implement your work plan and you're going to monitor it. You're going to figure out what's your baseline and what data are you going to track across that baseline as you go forward and monitor your program to make sure that you're meeting the objectives that you set out for yourself. But it is a whole culture change. So you hear the Plan, Do, Check, Act. That is one type of overall program analysis that you could do with a telehealth program. One that I really like when you talk about culture change is the book, and this came out in the 1990s, called Who Moved My Cheese by Spencer Johnson. And there's 4 main characters in this book. They're 4 mice, and then they're in a maze, and someone keeps moving the cheese. So we have these 4 characters. Him is our stabilizer. He likes a structured approach and a slower pace. Scurry is our producer, who likes a much faster pace, but is very short-viewed, very short-term thinking. Sniff is our innovator, who is very results-oriented, but has a long view of the whole program or the project. And then Haw is our unifier, and has an unstructured approach, but is very process-oriented and wants to get the whole team together on the same page. So if you think about these personalities and think back to your workplace, I'm sure you can identify people in your workplace that meet these different personalities. And the challenge is to get everyone to work on the same team and to divvy up all of the different pieces of implementing a telehealth program to people that have the appropriate personalities to tackle that objective and get it done in a timely manner for your work plan. Here's another way of looking at this called organizational physics. And again, we see that stabilizer and that producer and that innovator and that unifier all focusing on that one goal of developing a successful telemedicine program. All right, so when we assess our needs and our environment, critical access hospitals, we have the most contact with those through our Indiana Rural Health Association, have to do what we call CHINAs, or community health needs assessments, once every 3 years. And if you can access a community health needs assessment for your specific market area, that will get you a long way towards finding out what services are really needed in your community. And then a telehealth champion. When you start a telehealth program, the management team really needs to dedicate one person that is their job. You know, pull them back from other, running 50 different directions and say, okay, your job is to run this team, and give them the time to do it, to figure out the minutia of everything that needs to play into developing a program and making it sustainable. But your champion is going to be your cheerleader for the team, and really needs to be a visionary. So you do have to have that corporate willingness, and look at what services are available right now, what services could you add, what services really need to be delivered via telehealth for whatever reason. If it's transportation from the patients, if it's COVID and patients trying to stay at home, if it's distance from the medical center or the hospital or the clinic where you serve. And then you need to identify and prioritize the appropriate services. Here we are today really going to focus on maternal health, but telehealth can be used, the technology can be used to deliver a large range of clinical services. And then assumptions and constraints. And this, as you think about this, you want to think about physical space. And we'll talk about this, physical space for the provider. Where's the patient going to be? Are they going to be in a clinical setting? Are they going to be at home? What about broadband access? All of those things play into this. So there are two main areas of thought, and I have a black belt in lean healthcare. So you look at the deadly wastes in lean healthcare, overproduction, waiting, transportation, inventory defects, and Six Sigma is another similar thought process, but they're both about process improvement. And really in a culture change of bringing technology into your clinical practice, either lean or Six Sigma training is a huge boon to the leaders on your team. If they know how to think strategically and to eliminate waste from the whole process, they're going to have that mindset that is very key in developing a telehealth program. And this is something I like to throw in because it's all about eliminating waste. And I saw these several years ago in downtown Louisville. They use solar trash cans. And I thought, what a great way to use resources wisely and make the world a better place. All right, so we've assessed what we want to do. We know what kind of program we want to implement. Now it's time to develop and plan that program. So we need to pick a specific program model. Do we have the specialists that we need on staff to implement this program, to meet with our patients? Or do we need to contract with a specialist? Do we need to hire a third-party consultant to provide specialists for our program? And then where are the patients? Are they dispersed geographically? Or if you look at the entire state of Ohio, are they more in one regional area than another? That might dictate where you want your specialists to be if they do need to bring the patients in person. And obviously, you can't deliver a patient virtually. That's a pretty difficult thing to do. You need to, at some point, bring that patient in and have them receive clinical care in person. And what's going to best serve the patient's needs? So in order to serve the patient's needs, what technology do you need? And what's the best organizational model for developing that program? Do you have that human capital on hand? Do you have the facility resources? Do you have the money to buy the technology? Do you have the space to put the technology that'll be in a private location? And then who's going to provide that service? Also, legal and regulatory constraints. We're not going to dive into this too much, but we can answer questions on that in the Q&A as far as where is the clinical provider licensed and credentialed. And then what's your implementation approach? Are you going to use a phased approach? And we're not going to get into reimbursement either, but reimbursement for telehealth and telemedicine is very specific to Medicare patients or Medicaid patients or private payer patients. And it also is different based on the state where the patient is during the telemedicine event. So are you going to start by payer group? Are you going to start by location? These are things you need to think about when you're developing your telemedicine program. And we do recommend a phased or a pilot approach to this. Especially if you've got a champion that is a fetal medicine specialist, someone who can really rally the other physicians and the other caregivers in your hospital or in your clinical group. If they see their peers do it and they succeed at it, then they're more likely to try it if they're hesitant to implement technology. All right, this 5 whys is one of my favorite uses of my lean training, and it's really a root cause analysis is what it is. So I have a problem. I ran through a red light. Well, why did I run through a red light? Well, I was late for work. Well, why was I late for work? Well, I woke up late. Well, why did I wake up late? Well, the alarm didn't go off. Well, why didn't the alarm work properly? Well, because I forgot to set it the evening before. So digging down and finding that root cause analysis, I shouldn't be mad at myself for waking up late. I should be mad at myself because I didn't do my homework the night before and set the alarm for the appropriate time and make sure it was turned on. So as we think through our root cause analysis for what we're trying to do for our patients and the best thing for our patients, we need to align that with the business needs, the needs of the community. And I mentioned the community health needs assessment of the China before, and often you bring focus groups into that to help get the feel for, get the pulse on the community. And you need to make sure that your organizational mission and the proposed telehealth program fits in the mission of your organization. And then we've talked a little tiny bit about financial commitment. I mean, you might have to purchase technology. There might be some startup costs. And then also you're going to want to look at the billing, which we're not going to get into today, but what that revenue is versus the cost, and make sure that the project's going to be sustainable. And then you want to track your wins, track your savings. Scheduling, one of the things that we've heard a lot more about in medical journals recently is that there is a lot less missed appointments with telehealth visits versus in-person visits. So that's better for the revenue side of things because you're actually billing more of the visits that you're actually scheduling. Other things that are fairly easy to track in a telemedicine program are reduction in physical miles traveled, either on the clinical side, on the physician side, or on the patient side. You can track either side or both. And then effects on the local economy. If the patient's staying local and needs labs, and that revenue stays locally at your organization or another organization in your community where they're going to get their labs drawn. And then the carbon dioxide footprint from reduced travel. All right, so bringing that back to our hem, haw, sniff, and scurry. Again, thinking about the team players on your team and how you're going to best utilize them. So this is where we're going to really get into planning our program and the technology behind it. So you've got your objectives. You know you want to start a telemedicine program. But how are you going to do that? What are the steps underneath of that? So you need to identify your team leads and your team members and assign them appropriate roles and responsibilities. You can have the best telemedicine program in the world, but if you don't market it, if your patients don't know about it, you're dead in the water. So you need to figure out what's your best communication strategy, your marketing strategy. Are you going to use social media? Are you going to use direct mail? Are you going to place ads in the local newspaper or on TV commercials? These are all possibilities. You can hang up flyers at the local library. You know, there's possibilities are endless, but you need to, your team needs to be on the same page with that and make sure that somebody's responsible for making sure it gets done. As far as clinical policies and procedures, we recommend that you start with your existing policies and procedures and then just reread them from the focus of adding technology into that. You don't need a new policy and procedure manual just for a telehealth program. It's going to be very similar to what you do when the patients come in person. You're just going to adapt little parts and pieces of it. And then process integration. And this is all about training and repetition. Train your staff, train your clinical providers, and train your patients. What do they need to expect? What do they need to have with them, especially if they're at home, to take their blood pressure at home, to measure their girth, to determine how well the baby's growing, those types of things. So in our work plan objectives, we're also going to consider the clinical space. And I mentioned this already, is where's the patient going to be? Are they going to be in a patient room at an OBGYN office, or are they going to be at home? That makes a big difference in how you want to implement your program. Do they have adequate broadband access, internet access, wherever they are? Broadband access is the foundation to every telehealth program. If you don't have broadband access, then you're dead in the water. And then you're also going to need some equipment. So for a clinical space, you want to make sure that your internet access is with a reliable provider, that you have the appropriate service level agreements, either a 2 or 4 hour service level agreement. If the internet goes down, that they have a backup. And that all plays into the maintenance and service agreement and support agreement that you have for the software and hardware that run your internet access. If the patient's at home, maybe they're going to use a smartphone, maybe they're going to use the data plan on their smartphone, or maybe they've got internet access at their house, maybe they're going to use a computer or a tablet. You need to have some scenarios and some patient education to be able to meet the needs of those patients and the variety of that. Interoperability and scalability. Now here we're talking about electronic medical records and the integration with your EHR. Some EHRs do have video modules in them, more and more are adding them. But then how are you going to get the data from your whatever audiovisual platform that you're using with the patient? How are you going to get the data from the clinician into the EHR? There's a lot of varieties of ways to do that, and a lot of it depends on your video conferencing platform and your EMR platform. And then again, organizational approval, if you have to spend money, if you need to divert resources. And then looking at outcomes. So by nailing down your outcomes and the data that you need to prove whether or not you've met each outcome is going to help you to have a successful program. Because if you have a goal and you don't have a baseline, how do you know if you've met that goal? So here's where we get into our work plan. What are you going to track so that you can achieve your goals? So I've talked about some different types of data that you might want to collect, about miles saved, reduced missed appointments. And then you always want to do a little course correction. You're always going to want to check back weekly, monthly. As you get into it, maybe you check quarterly. But check and see if you need to tweak your program goals and objectives as you go through the program, especially if your goals are volume-based. And so plan your program improvements so in increments so that you can really see where you're at and what do you need to do to achieve the next level. So here is a sample work plan template and a URL where you can get that. We do a lot of HRSA grants at the Indiana Rural Health Association, so this is one we use a lot with a lot of our grants. But you can use anything that you want to, any style of work plan, as long as you've got some specific measurables in it. So here, this one is a very common low-hanging fruit kind of thing about reducing wait time in the emergency room for psych consults. But the biggest thing that you need for any work plan is your SMART goals. So your goals have to be specific, measurable, achievable, relevant, and timely. Don't put a goal out there for yourself that's such a stretch goal that you're never going to meet it. Put out some easy goals and then overachieve and get them, and then put out some stretch goals as you go on. So as you look through your work plan, you look at your overall goal for the program and what is it that you want. In this particular sample work plan, we want to reduce wait time in the emergency room for psych consults. So how are we going to get there? Well, we're going to do that by providing telepsych services in the emergency room or the emergency department. What are the steps to getting there? Well, first we have to find a space for the patient where they can have a private video conversation with a specialist using technology. And we have to make sure we have a psychiatrist, either somebody on staff, contract with an outside organization, however you want to get that done. And then who's going to do it? Who is going to, on the team, is going to be responsible for the different pieces of the program that need to happen. So you're going to have a team lead. And in this example, we have 2 team members. So you need to decide what your timeline is. Here I put the 3rd quarter of 2020. Now, at the end of August, third quarter 2020, that's, right here, right now. That's a pretty stretch goal. Maybe you want to say the fourth quarter of 2020 or the first quarter of 2021. And then how do you know if you've really achieved that goal? So we have a goal here. By the end of third quarter 2020, we'll see 20 patients via telepsych. So again, based on where we're at in the calendar right now, that's a stretch goal. But is it doable? If you've got all the pieces in place, then yes, probably. But those are things that your team is going to have to talk through. And then the last step, the implementation and monitoring, is the basic team meetings that happen after you implement. You're going to go back and say, well, what went well? What do we need to work on? Those types of things. And then you can improve the program as you go on and continue to monitor it. So that's all about the Plan, Do, Check, Act. All right. So that was a very large conversation, but a very, very, very important part of developing a telemedicine program, because without a proper work plan and goals and objectives and timelines, you're never going to get where you're going. So this next objective, we're going to talk about virtual visit etiquette. And I think a lot of us are much better at this than we were 6 months ago, just because of what has happened with the public health emergency. So prior to COVID, we would talk a lot about a telemedicine room in a primary care office that is basically your normal patient room with the normal things that you would see: blood pressure cuffs, a laptop or computer, maybe a comfortable chair, and an exam table. And that's really what the patient needs, is some type of smart device or computer with a webcam. And that's really what the provider needs. That's the basic equipment that a provider would need to have a video consult with a patient. So it really changes when the patient's at home. And the only reason this works right now with reimbursement is because of all the waivers around COVID-19. What we're starting to see in the proposed physician fee schedule for 2021 is an extenuation of those waivers to the point where they'll actually be codified. And there's many bills going through state Medicaid programs and at the federal level to try and make that happen. But when you see a patient at home, some of the basic things that you need to consider is that the patient is in a private space. You don't want them at a fast food restaurant trying to use the Wi-Fi and having a private conversation and other people around them hearing all kinds of protected health information. You do need to get consent from the patient for them to be seen via telehealth. We have other videos that we've done in trainings and information on our website about consent. It is a little bit different in each state. The basics, you can procure consent via audiovisual, but then you need to make sure that you follow up with written consent, and you can do that with a patient over email, over a secure patient portal, through snail mail if you need to. And then the other big thing is, how are you going to get those vital signs from the patient? What equipment does the patient have in their home, or what equipment might you as a provider or an organization need to provide to the patient so that they can take their vitals appropriately? So the basics of video conferencing etiquette, we're going to talk about lighting, what junk is in your trunk, and then eye contact. So optimal lighting is a diffused light source. You want to be lit from the front. So you want your patient to be lit from the front. You as a provider want to be lit from the front. You don't want a halo behind your head, and you don't want things growing out of your head. You don't want to be backlit from windows. In this particular example, this woman has a lot of lighting in the back. And it's almost hard to look at her because of that harsh lighting behind her. But here at a different angle, it's much easier to look at her and see and concentrate on what she is saying. Here, this physician is backlit. It's distracting. It's so bright. But if he closed his blinds, it would be much better. In this, these two examples of background, these look like a messy college student dorm, maybe something like that. You wouldn't really trust this person if they were coming across as a provider. So you need to think about what's in your background. And wall color. If you've got control over the environment where you're going to be, then think about wall color. This beige color is not a bad color, but it's pretty cluttered as far as a background goes. If you turned and had the stumps behind you, that's not a bad background, but you might want a nice clean wall behind you. And studies show that ideal wall colors are ideally light blue and light gray, because a white or a light wall can darken faces and a dark wall can lighten faces, so you don't get the pigmentation that's appropriate. And those two colors work well with all skin tones. So again, if we had a consultation between these two providers, we want to see that they each have a clean and uncluttered background, because then they're going to be better able to focus on the conversation that they're having. So that is key. So when you think about a clean and uncluttered background and you think about eye contact, it doesn't come naturally. It's sometimes difficult. I have two monitors here and my webcam is right here. So I'm trying to focus my attention on my webcam, but my slides are over here. So I will glance at my slides and then I will come back so that I can maintain eye contact with you, my audience today. So it's really like getting your picture taken. And you want to make sure that your eyes are focusing on your patient so that you can show engagement with your patient. You don't want to be down here writing notes and not telling your patient what you're doing, or glancing off at a screen and talking to the screen and they're not going to be able to hear you. So you want that communication between the provider and the patient. Distractions. Distractions can come in on the side of the provider as well as the side of the patient. And you need to do your best to minimize those distractions. Let people know, hey, I'm going into clinic. I'm going to close the door. You're going to lock the door. Maybe you put a sign on the door. And try not to let yourself get distracted. Same thing with writing notes. Tell your patient, okay, hang on just a second. I'm going to make a note here. And then come back to the patient and again, reestablish that eye contact. External noises. Sometimes there's not a lot you can do about external noises. If your clinic room is right by an elevator or right by a noisy stairwell, or there's traffic outside. But some of the things you can control is the acoustics. Some of that will be part of the equipment that you purchase, making sure you have a good audio, good speakers set up. You can purchase paint that is sound dampening. You can put carpet on a floor. You can put drapes on a window. All of these things will help deaden the echo in the room where you're at, either on the patient side or the provider side. And then coming back, you want that clean and uncluttered view between the camera and the person. All right, so our last objective that we're going to cover today is physical examinations, and how do we incorporate that into virtual visits? The National Technology Center has a great website, and they have a lot of tutorials on different types of equipment, so you can look at those. But what about the patient? Can they take their vitals at home accurately? Most homes have a scale, a thermometer. They might have a blood pressure cuff at home. They might have some type of a fitness device that they wear, or an app on their smartphone to take their pulse, or some other vital signs. But I was just searching Amazon when I put these slides together, and there are a lot of blood pressure cuffs out there on the consumer market that they could use to take their blood pressure, and they would also give off pulse. Sometimes you can get the pulse oximeter and other things with that are not that expensive. So that's something to consider. You might decide that, hey, we're going to include a tape measure and a thermometer in all patient kits so that if they need to take vitals from home, they can take some of those things. We do recommend that you put in the chart when you document the visit that the vitals were provided by the patient. And then there's several ways you can reach back out to us if you have additional questions. We have our website, our Facebook page, our LinkedIn page, and then you can sign up for our newsletters. We send these out at the beginning of each month with the events for the upcoming month and my contact information. So at this time, and I'm not sure exactly who's going to read questions for me, but we will start to take questions. All right, as people are thinking and typing their questions, Autumn, do you want to let folks know about the survey?
Absolutely, Becky. Attendees, I'll be sending you out a thank you for joining us. And also there will be attached a link for SurveyMonkey that I would love for you guys to fill out. It helps us know how we're doing. So you'll have that exact attachment. All you have to do is hit that link and it will take you directly to our survey. And thank you guys for joining us today.
Thank you. Yeah, so this is, and I expected this question. A lot of patients that do not come in due to COVID, and how do you check fetal heart tones? That is a really hard one, especially if they're at home. What they really need is some type of a digital stethoscope and the software to do that. And that's one area with this project that I'm going to be diving into more, is the costs and feasibility to do that. There are apps out there, so that'll be part of your due diligence as starting up a telemedicine program and figuring out as an organization which way you want to go, if you want to purchase equipment or an app for your patients to be able to take those, and just all the details that are involved with that. Any additional questions today? We've got a question. I'm sorry, I'm supposed to let Luke read these.
Okay. Are there implications for use of telehealth with lactation?
There are programs out there for lactation services. If you contact us or email us at my email or info@umtrc.org, I can make some recommendations, but there are a lot of successful lactation programs out there. I think we're going to see, and a lot of this is because of COVID, that we've seen such a focus on delivering services via telehealth. But I think we're going to see a lot more innovative programs around delivering services to patients while they're in their homes. I've been working with some folks up in Michigan on a grant that is specific to their WIC program in Michigan and delivering services, including lactation, to their clients via telemedicine. So I think there's going to be a huge amount of growth in technology devices for consumers to purchase, to enable them to do more with their vitals and have more data that they can share with their providers via telehealth visits. Any other questions? All right, well, thanks everyone for joining us today. As Autumn said, you'll be receiving an email from us once the recording is posted to our website along with the slides. And feel free to reach back out if you have additional questions.